Hello and welcome to another Wound Healing Society Fireside Chat. I'm Kyle Quinn, and my colleague Mitch Sanders and I are co-chairs of the Wound Healing Society Communications Committee.
We are pleased today to have Yash Mantri, Caesar Anderson, and Jesse Jokerst joining us for the first Fireside Chat in March with a paper entitled Photoacoustic Monitoring of Angiogenesis Predicts Response to Therapy and Healing Wounds. Kyle, before you start with questions, Jesse, didn't you were a finalist for the Wound Shark Competition 2020. Did you win? You're on mute, Jesse. You're still on mute.
Thank you. I did win, and so really appreciate all the help of the Wound Healing Society over the years, and really great to participate.
I didn't get you an award. Did you get a bag of money from us too? Did you get a check for $500?
Yeah. It was very helpful to attend the meeting.
No, wonderful. I'll send you an award. I have to pick up the award for this year. And so I'll pick up 2 awards and I'll get you a nice little plaque with your name on it. But it was so funny when I said, the name sounds really familiar. And I said, oh, yes, our winner from the Wound Shark competition. So wonderful. Let's get started. Kyle, why don't you take it away with questions?
Yeah, so why don't we start by talking about photoacoustic imaging. Could you explain how that works and how it differs from traditional ultrasound?
Sure. So in traditional ultrasound, you have a device called a transducer, which is basically emitting and receiving pressure waves. And so in regular ultrasound, you are basically bouncing these ultrasound pressure waves off of tissue. And as those pressure waves come back to the transducer, it uses that to create an image. So sound in, sound out. In photoacoustic imaging, it's a light in, sound out technique. And so we're using very short light pulses, so think nanosecond light pulses. And when this light goes through tissue, it's absorbed, and it causes a very short and spatially confined heating and thermal expansion event. So when stuff heats, it swells. And so we're basically causing the tissue to wiggle, and when it wiggles, it creates pressure waves that then back propagate out to the transducer. So light in, sound out.
Do you mind if I ask you a question? Jump in. So with the cool thing about this is the device has a tight bandpass LED, right? And before we used to use YAG lasers for stuff like this, but they're too bulky and they're not really safe to use in the theater. And so can you talk a little bit about that?
Yeah, this has made the entire clinical workflow incredibly simpler, easier, because Dr. Anderson gives us a relatively short amount of time. He sees a lot of patients, so we've got to get into that room and out. And so trying to roll and bounce this an OPO laser through the clinic would just be a real deal breaker. And these LEDs, you can drop them on the floor, pick them up, dust them off, and they're still good to go. Of course, they have significantly lower fluence, so they're delivering less light energy, but we can do averaging and other signal processing approaches to salvage a lot of the signal to noise and signal to contrast to background. Yeah.
So in this study, you've been looking at angiogenesis, and we've seen a number of imaging technologies over the years applied to wounds to try to extract information related to angiogenesis or perfusion or oxygenation. And what makes photoacoustic imaging particularly attractive compared to these other techniques?
Sure. I definitely want to get Caesar's take on this, but what I love about the technique is the ability that we're overlaying both anatomical information and molecular information. So we have still have the sound in, sound out ultrasound. So we're seeing surrounding tissue anatomy, we're seeing bone surfaces, but then we're overlaying molecular level information in terms of the perfusion and oxygenation on top of that. I'd also note the really nice 3D tissue volumes that we're getting. So we can scan in the X, the Y, and the Z direction. So Caesar, could you maybe comment on how this compares to some of the other technologies you've seen?
Sure. So, I mean, as you mentioned, one of the active benefits that this technology really sort of distinguishes itself from some of the others is that in real time, not only are you able to get a real appreciation of what's going on from a vascular standpoint, in that microvascular standpoint in the wound environment, But you can also sort of couple that with a 3D image. So often you'll have these, very significantly challenging wounds, whether they be radiated or with a heavy fibrotic and scar burden, that that there is some degree of perfusion you hope coming to the wound, but you can't A, quantify it, and B, you can't really localize where the bulk of the activity from a perfusion standpoint is coming from. And this technology really sort of helps you hone in specific locations where the perfusion gradient is substantially much more improved comparatively to other parts of the wound environment. And really no other modalities do that. If you look at some of the other modalities that we have for trying to assess perfusion, like let's say TCOMs or Sensilase, these perfusion types of corollaries that we use, they're sort of rough and dirty. I mean, the TCOMs you can get as close as you can, but again, there's really no visualization of what's going on. And then from a reproducibility standpoint, this is a machine that is very, very well. From my eyes, watching Yash, the magician, apply this, is very user friendly. So this is also a big distinction difference between some of the other modalities that we have there and this one.
Yeah, thanks. So, we'll jump into some of the results. I mean, you found some promising results showing that the photoacoustic intensity changes may be a predictor of time to heal. Could you talk a little bit about that and how you settled on choosing that as a metric for predicting time to heal?
So I would maybe make two comments. One is that we are just overloaded with data right now, and so we are actually using some very crude and manual processing of the data. And so, we kind of picked this bulk PA intensity in the wound bed as a simple first proof of principle imaging biomarker. There's a lot of work going on in the background and using deep learning and machine learning to have more sophisticated ways of processing the images. So, this bulk PA intensity, for one, it was simple. Two, going forward, we want to collect these images at two different wavelengths. And so right now, all of the data in this paper was only collected at one wavelength, and that's because we had more intensity if we only used one type of LEDs. Going forward, as this technology improves, we're going to use two sets of LEDs, and that way we can discriminate between oxygenated and deoxygenated hemoglobin. And so Yash has been doing some scans on patients coming in and out of the hyperbaric chamber and seeing some really encouraging results there. It's just as plain as the nose on my face, the difference after they're in the hyperbaric chamber. So that's going forward. But yeah, so that was the point of this initial imaging biomarker.
Can you talk a little bit about there wasn't a lot of difference. Well, you didn't have a lot of exclusions in your inclusion-exclusion criteria. So you excluded anyone with a bloodstream infection, I guess, but you didn't count out. It looked like some of the wounds may have been infected, but you didn't exclude that. And the only thing you did exclude was the size of the wound, right?
Yash, can you please talk a little bit more about exclusion criteria?
Yeah, I think the main exclusion criteria there were, as you said, like people with bloodborne infections, but also people with implants near the wound area, because that can have signal generation with the photoacoustics. But like people did have infections in there, and I would scan them before they were treated by Dr. Anderson on the day. So that was and it still felt fine, and we had a sterile covering around the probe as well to stop the spread of the infections as well.
So you found this inverse correlation with hypertension or high blood pressure, and the question there is, were any of these patients being treated for high blood pressure, or no? They came in with very high blood pressure that were untreated.
No, what I would say is that just a couple of clarifications. Part one, in terms of infection, the patients that we treated, majority of them were not infected. I mean, quite often, you know, you can look at a wound and just from what it looks like, you may think that, oh, this looks like an infected wound. But our patients are very closely monitored, and unless there's frank pus coming out of the wound, bad odor, etc., I would say probably all of those patients were the bioburden of disease was actually quite low, and I wouldn't have classified any of them as, you know, some sort of active roaring infection. The other thing is that most of these patients, from a hypertensive standpoint, yes, they're being followed by their primaries. They're being treated. You know, there was nothing different from the standpoint of where that, you know, these are completely uncontrolled. It's your general population. So if their primary are managing them from a hypertensive standpoint, that continued on. Of course, we had, you know, intervals where, let's say a patient, you know, is not taking their medication, but this is just like the general clinical population out there. So antihypertensives were being applied if they were prescribed. Yes.
Okay. Because I was just wondering, Dr. Anderson, if it, you know, if they weren't getting good compliance, then or before you treat a patient, you make sure their hypertensive behavior, their high blood pressure is under control before you even try and heal a wound. Maybe that would make a major difference.
Sure. So, you know, these considerations always come up, and whether it be antihypertensive, glycemic control, all of these parameters certainly, you know, make an impact. But again, in the real world setting, and I think most of the clinicians will you know, do a nod on this. It's almost impossible to get some of these patients tightly tuned before you can really dive in and get proper healing. What I can tell you is that the majority of these patients, especially with the very severe chronic wounds that are scarred, fibrotic, whether they be post-operative or post-radiation, all of these patients are on a number of other treatment modalities, and most of them are not fine-tuned, but we were still able to get them to the next step. We're still able to get them healed with the interventions that we do, which from an efficacy standpoint, you know, this is the sort of thing that really matters, in that, you know, most clinicians can't get their patients optimized completely, but if they can use a modality that can sort of help them assess in real time what they're working with, and see how that influences some of the treatment decisions that they're making, this will be a really big additive component to the our treatment modalities.
Oh, do you want to ask the question?
Sure. Well, yeah, I'd like to maybe switch over back to, you know, you mentioned discriminating oxy and deoxyhemoglobin in the future using two wavelengths, and I'm curious if there are other possible chromophores absorbing, you know, within the 850 range that you looked at here, or you know, even as you go to two wavelengths, and you know, what other possible sources of contrast are there that you could exploit?
Yeah, so, you know, the main things that absorb light in tissue are hemoglobin, deoxyhemoglobin, water, melanin, myoglobin. So the standard things that you would see in a biomedical optics textbook. And so absorption is additive. So one of the strengths of this technique is the ability to look at different wavelengths. But this is really important. And so one thing that Yash recently also published is the impact of skin tone on photoacoustic signal, because you could imagine as different skin tones have different amounts of melanin, that could and so we did see some significant differences between people with very dark skin tone and very light skin tone. But what's nice is that, you know, it's relatively straightforward to quantitate skin tone, and so by doing this in healthy subjects who we know had a 98% oxygen tension, we could develop some ways of compensating for the lower fluence for these people with darker skin tones. So we didn't integrate those compensation methods in this current work that was just published, but going forward, that's definitely something we want to consider. And so then just to maybe close the loop a little bit on, what are you actually imaging? So we're arguing that we're imaging perfusion. And so we don't, in this paper, have a true, independent measurement of that. And so it's a kind of a tough measurement to make. So one thing that we did do, though, and this is a paper that's in review right now, but there's a preprint on medRxiv, is Yash looked at patients in the dialysis clinic. So these are people who don't have wounds, but when they go into this, dialysis is a great place to do imaging because it's a very controlled setting. And these people, when they have these liters and liters of fluid pulled off, their blood pressure drops pretty significantly. All of this blood is shuttled to the interior of the body. There's less peripheral perfusion. And so we saw this really, really nice correlation between this change in blood pressure and the decreased photoacoustic signal in the periphery. So this is one of the things that the NIH study section pushed back on, is how do you know that you're really imaging perfusion? And I hope this is a way of proving that. And then, going forward, we also want to use some of these other technologies like TCOM and Sensalase that Caesar mentioned.
Are you able to discriminate fairly well? Like, are you far enough away from water? Because I would imagine, like, even during dialysis, you're going to have some changes in pressure, interstitial pressure. And
yeah, water's more of a problem above 1,000. So between 700 and 900, its absorption coefficient is quite low relative to hemoglobin.
You've also got another paper on using this to predict pressure ulcers, which was pretty cool. And the question is, could this be something for predicting reoccurrence of wounds?
Yeah, so this is of significant interest. The pressure ulcer one was in an animal model. And, where I get stuck there is, what does this look like clinically? Like, are you going to walk around and scan everybody who's in the skilled nursing facility? That doesn't make sense, right? So maybe in 10 years, there may be a smart bed sheet that kind of does this automatically. But more importantly is people who are at risk of relapsing. And so there was a really well done New England Journal meta-analysis that showed that there's, I think, almost up to 40% chance of relapse in diabetic foot ulcers. A lot of those people are also on dialysis. Dialysis is a closed system. These people always show up. And so that might be a cohort that could really benefit from monitoring relapse because it's such high risk. Yeah.
Well, Jesse, I would also add that the wound community is already sort of looking at trying to implement modalities for looking at recurrences for pressure ulcers. And I would classify the diabetic foot ulcer as a pseudo pressure ulcer, since most of these patients that develop these foot ulcers have significant neuropathy, and it's a ongoing pressure element that leads to ulceration and so forth. We have modalities where after they're healed that you can sort of try to monitor their risk of recurrence by doing pressure mapping. And then we have that for pressure ulcers where there are nursing facilities and hospitals that are using pressure mapping on mattresses, and perhaps integrating something like this, where not only are you able to get some pressure mapping, but you can also early identify perfusion gaps in the tissue, which is really the ultimate sort of rate limiting step for ulcer development. I can see it, in the future, certainly potentially being integrated.
Absolutely.
So I'm curious about some of the other next steps you're looking at with this technology. You mentioned machine learning, deep learning. Are you thinking are you using that more for denoising or for segmentation and trying to actually identify, exactly how many blood vessels? Or...
Yeah, both actually. So we published a paper last year about training the machine learning algorithm on lower and lower and lower amounts of delivered light. So we used a laser which had a lot of fluence and then blocked increasing amounts while imaging the same thing. And so that's what we used for training. And then we gave it test data using the LED. So the LED would have less fluence. And so that was quite promising in terms of increasing our signal to background and signal to noise. Segmentation has been studied in the field for a while now, right? For not just for ultrasound, but for lots of other imaging modalities. And so we're trying to adopt lessons learned there. So yeah, they're both active areas in image interpretation. The clinicians, they're busy. They need a go, no go. They don't need to read images. So yeah.
Yeah, and I saw you use this device to do some molecular imaging looking at oxidative stress in the past. And, are you thinking about looking at oxidative stress within wounds as well, maybe preclinical model or?
Yeah, so preclinical is straightforward. So we've developed nanoparticles, small molecules that have a change in their light absorption and hence a change in their photoacoustic signal as a function of things like peroxynitrate, hydrogen peroxide, superoxide. The translation is so much harder, obviously, because we're dealing with a contrast agent. But I think for doing some preclinical studies, it's a great tool.
Yeah, and certainly, one of the major advantages of the current use of it is that label-free nature of it.
Yeah, exactly.
Mitch, you have any other questions?
Where do you see the research going next? How can this translate more into the clinical practice?
Yeah, so I think the main thing, well, there's a couple things we're looking at. One is the watching relapse in the dialysis clinic. So that's an active study that's ongoing. Two is patients who are in and out of the hyperbaric chamber. So Yash is imaging people with maybe diving injuries, or these are people that don't have wounds. We just wanted like a positive control that you have healthy tissue and you can see a difference in oxygenation pre and post hyperbaric treatment. So that's been super encouraging. And so then the next step is to image wounds pre and post, because if we're not seeing a change in oxygenation in the wound, there's no reason to keep putting these people back in the chamber, right? It's time to pick a different treatment modality. So that's got me really excited, those two cohorts. And then the third thing would be, so, this paper in wound repair and regeneration was kind of a hypothesis generating technique. So we identified this imaging biomarker, but to really test it would require a more robust cohort. And so those are the three things that I would love to do, and that we're working on getting funding to do.
We have a lot of colleagues that work in topical oxygen therapy. I'm wondering if you could those companies to demonstrate the value proposition of their device. I think it's kind of like why negative pressure, when we got it to smaller devices, there was more compliance. I think with topical oxygen therapy, because it's so much easier to use and you can practically wear it all day, you're getting better outcomes than you're seeing with hyperbaric. So it could be a real great opportunity for you to follow.
Yeah, I actually don't know much about that at all. If you could connect me, that would be really helpful.
I know many of the CEOs in every single company in that space.
Okay. Yeah, I would love to learn more.
Great. Wonderful.
Just as a nice, when I hear topical oxygen, I just can't, be too quiet about this. But we've done a number of studies also looking at topical oxygenation and its efficacy for promoting wound healing. And the truth of the matter is the data has really been quite limited and hasn't really shown favorable outcomes. But these are things that can certainly be further studied. And but overall, from a clinical standpoint, EpiFlow and other topical modalities just really haven't really cut the mustard.
Sure. And this may be a way of understanding that mechanism too. Yeah. Of like, is it a depth issue, or is it why might these failure events be happening?
Yeah, it seems like it may be a depth issue in terms of the oxygenation perfusing, from atmosphere into the tissue. That's been the most rate limiting component compared to hyperbarics, where the oxygenation is from within externally. the topical just hasn't been able to have good tissue penetration for healing.
Because I've seen some good clinical data around that, and there's even the Granulox, which is delivering oxygen through hemoglobin, seems to have some pretty good clinical data around that as well. So maybe it's very device specific, but using your approach could really help us better understand what works and what doesn't work. So
absolutely.
That's very exciting. I want to thank all of you for joining us for the Fireside Chat. I apologize. I have a call with the FDA I have to run. But great seeing you, Jesse and Yash. And Dr. Anderson, thank you kindly for joining us. And I'll let you know when this is up. It'll probably be up in the next couple of days. But
awesome.
Look forward to seeing you at SAWC WHS.
Thank you, guys.
Take care.
Thanks.
Stay well.